Hi, it's Dr. Noel Williams, Optimal Health Associates, Oklahoma City, Oklahoma, January 31st, 2022. COVID update. I haven't done that many lately because it got banned from YouTube for a while and was kind of in the midst of COVID and had COVID and so had a little break. So what's the update? Well, cases in Oklahoma, we're at about 8,800 a day. I believe I just looked at the numbers, but they blur so much. We're approaching 1 million documented infections. We've had way more than that. And somewhere around 12,800 deaths, maybe, or 12,500 deaths, projected by the end of the pandemic to be about 13,600 currently by some health statistics. In the United States, I think we're approaching 900,000 deaths. You can't keep track of how many people have been infected because, the Omicron numbers are so high and people can't get tests, and the false positive rate is there, but the false negative rate is even higher. So it's just a big mess. Hospitals been pretty filled up in Oklahoma City and throughout Oklahoma, coming down a little bit at some of the institutions in Oklahoma City, which is good news. So that's all positive. The thing that's happened with Omicron is simply volume. If you have, 8,000 or 10,000 established cases a day versus 4,000, there's a huge jump in hospitalizations, or a big jump in hospitalizations just relative to the just increase in numbers, even though less people are getting super sick. But really the reality is there's probably double, triple, or quadruple the number of people getting COVID than we're recording. Interestingly enough, trying to figure out who in the hospital actually is admitted for COVID versus happens to be admitted and has COVID, maybe as high as 50% of the admitted COVID patients were there for something else. So that also makes all the data interpretation difficult. What we do know, though, is with the state's adjustment, we probably had an additional 122 deaths over the last several days than were previously recorded, because they're trying to look at it a little more specifically. In terms of Omicron itself, our clinical experience, I think in most people's clinical experiences, the vast majority of people are fairly easy to treat with just steroids and antibiotics. Talking about other things to treat them with is, again, the good way to get banned. But again, I would say that the ivermectin role has disappeared with Omicron. It's too rapid. And what we're finding is you just need to give them supportive care to get them through it with, again, steroids and antibiotics. And we've had very good success with that. We've had one hospitalization in almost 500 patients since this began. And thankfully, no deaths. We've had another near hospitalization too. But again, it's a relatively tiny number compared to the number of people we've treated. With things. So again, very important. Stay on your multivitamin, stay on your zinc at least 3 times a week, stay on your vitamin D. All that's good for you in general. Stay on your omega-3. I prefer fish oil because it's, we're omnivores and we don't have the enzymes to convert all the natural oils into the exact same thing as what's in fish oil. And fish oil is a very important anti-inflammatory and blood thinner. And when I'm saying blood thinner, keeping your platelets normal so they don't over-aggregate if you get inflamed. Not that it's so much a blood thinner per se. Think of it as a normalization agent. So that's kind of where we are. I mean, we're definitely look like we're at the peak, and it should be coming down now. And looking at people's antibody levels who are 3 and 4 weeks out, they're off the scale. Measurable is interesting. I had someone in today who had an incredibly high antibody level at the end of September, just shy of 2,500, and she just had Omicron and around January 1st. Because how does that happen? It's because original antibodies, either from original infection or the vaccine, don't match Omicron. And so you can still get the infection even if you've been vaccinated. Now, the thing we're seeing again is those patients are much less likely to get hospitalized or die from COVID than people who've not been vaccinated. But again, the uniting factor to virtually all the patients who get very, very sick is they're obese, they have multiple comorbidities. So, and they're older. The current vaccination average age is a little bit over 60 for hospital admission, and the death rate is closer to 70. And then for admission, that was for unvaccinated. Sorry, about the average age is 60, and the average age of death is somewhere between 65 and 70. The average age of admission for people who are vaccinated is 70. The average age of death is 80. And again, all these groups are very, very, they're much more illness prone and documented people who aren't potentially doing that well. Some people have been saying that Oklahoma's done the worst of any state handling this. I mean, clearly they're mixing some of their statistics. Yes, we've had some problems, but it's all about buy-in to certain subjects. Our vaccination rate is definitely in the middle of the 50 states. We were very good out of the box. Keith Reed, the commissioner of health right now, the interim commissioner of health, has done a fabulous job on rolling out vaccines. When they came out a little over a year ago, his team did great. We did much better than the vast majority of states. But we've had our problems because vaccine adoption hasn't been as good as we've wanted at times. But again, we rolled the vaccine out very, very well. We've treated more people if you got sick, Oklahoma City was the place to be. I mean, Integris, I think, has done more than 1% of the ECMO patients in the world, and has the care at Integris has been fantastic. The care at Mercy's been fantastic. Saints has been fantastic. Norman Regional, Transcendent, and OU's been fantastic. So the area hospitals, and Midwest City also, very, very good. So the area hospitals have really, did I say St. Anthony's? Yes. Okay. Have done, if you were to get sick, this was the place. But the problem is, the first year when there wasn't a vaccine, we have a lot of really unhealthy people here. And so that didn't help things. I mean, you can argue one way or another about the mask, but I think when the data in the end comes out, the most important thing is going to be your baseline level of health is what determines your fate with COVID. And it's that simple. And since our baseline level of health in Oklahoma has been bad for a very long time, with obesity, poor nutrition, and smoking, we were going to have more problems. I think relatively we've done very well with the cards we were dealt. And that's just how I look at it. I think the state health department has done a very good job and really has overachieved, especially when you consider who they've had to deal with, which is a lot of people in the state who are very argumentative about getting vaccines. And so, and again, I'm always respectful, unlike some people, about someone not wanting to get the vaccine. You just have to understand, if you don't get the vaccine, you might get sicker. And I am surprised that people who get ill with COVID seem so surprised that they got that ill. And we have definitely seen that over the last month with people within my practice. And I think many providers in the state see that, where people who've never gotten vaccinated get very frustrated that they've gotten COVID. And then they get very frustrated that there isn't antibodies for them. And they get very, it's like, this is what we've been telling you. And so, and again, if I'm all for people making their own choices, but don't be gritchy if you've chosen not to get the vaccine and then you get a little sicker than I did. And I didn't think Omicron was a breeze. I thought it kind of was terrible, well, reasonably terrible for someone who didn't get that sick. I mean, it was exhausting. I felt crappy. I had tremendous bone pain in my back. So, and that's how it is. I mean, Kim's a month out and still has a chronic cough. Is your taste and smell back?
Yes.
Yeah, taste and smell's back good, because she was not happy. And we all know the saying, if your wife's not happy, you're not happy. Anyway, I'm kidding. But that's the main thrust of it. And so hopefully we have about a month left. Omicron will then really dissipate. and hopefully we'll have 6 months of more normalization. And the thing is, we have to get back to normal. Anyone who thinks that we can continue the baloney of what we're doing doesn't understand viral transmission and micron size, pore size, and aerosolized droplet size, but that's okay. People are going to give their opinion, like Neil Young and all these people who are, first I thought media people were, for the most part, idiots for making political commentary. Now the media people are making a lot of comments about medical stuff, and I just don't understand why anyone would listen to them at all. But, and I think anyone who believes that, what's Harry's wife's name? Merkel?
Megan.
Megan. Anyone who listens to those two, turn me off, please. Thank you. I don't want you to listen to me because there's no point. So, what questions do you have, Kim?
Okay. With Omicron, if you have a really mild case, do you get just as good of antibodies?
Yeah, antibody levels and T-cell immunity. Antibody levels and T-cell immunity. Let's go over that again. If you have antibodies, your antibodies are going to be very helpful to you. And it's not how sick you get, it's how good of an immune response you get. And people with mild illnesses get good antibody levels. We've seen it time and time again. That's what the data shows. And again, even if your antibody levels are nil after the infection, we know that, but with a true infection, we know you got it. We know that 4 out of 5 of those patients have thorough and complete T-cell immunity, because that's what the papers say. But again, we don't talk about T-cell immunity because T-cell immunity isn't something you can measure easily. And God forbid we would talk about it, because it doesn't promote utilization of boosters. And utilization of boosters is about, I would say the manipulation of it is about the antibody levels are so important. It's if you have antibodies, you're going to have T-cell immunity 95+% of the time. If you don't have antibodies levels, you're going to have T-cell immunity after a true infection 80% of the time. So that brings us to a total of, in 100 people, 95 are going to have antibodies. So that's going to give them immunity, or at least partial. And of the 5% who don't, 4% have T-cell immunity. And so that gets you to 99 there. And if you looked at it the other way, probably 95% of people have T-cell immunity and 5% don't, but of that 5%, probably 4% have antibodies. So, again, it's really basic stuff. Immunology has become totally distorted because of certain figures in the media. So don't listen to anyone at the CDC or the FDA or NIH. Go to some of the people at Stanford. Listen to the people out of Johns Hopkins. They're going to give you a lot better data.
Okay. This person tested positive early December here in Oklahoma. Could that have been Omicron? Was it here that early?
It could have been, but it was very low. And so I can't remember. I think by about the 15th, we may have been at about 30%. So it would have been more likely to have been Delta statistically. There's very good cross protection with Delta, we believe, against Omicron, because it's like, genetically, Delta's here, Omicron's here. There's some, in terms of the progression genetically, Omicron has virtually all of the antigens, at least scientifically so far that we can see, that Delta had, plus others that dumbed it down. So the Delta looks like we're going to have pretty cross reactivity to Omicron. But we have had for sure 2 people with a positive PCR who were symptomatic with Delta in the mid to late summer, when the prevalence rate was like 95%, who have gotten reinfected with Omicron at its peak, when it was 99% or 98% of the tests in Oklahoma. And so it is possible to get reinfected. It's going to generally run about 1% to 2%. Both of our cases were extremely mild, which is what we'd expect. And again, if you look at the classic data on reinfection, the hospitalization rate for reinfected people is, somewhere in the range of one in thousands and thousands and thousands. I mean, I've given this data before looking at it. I think it was one reinfected person out of 2,000 patients of 100,000 patients studied with prior infection in Italy. And it was one hospitalization in 125,000 prior infected people in the country of Qatar. So we just have to kind of keep that data in the back of our minds. And those numbers get confusing, but it's teensy-tiny numbers. So, and again, it's a paralyzed thing, a paralyzation. Are you paralyzed by fear or not? I'm not. You walk around, who cares? It's about socialization. Everyone forgets socialization. They're never going to count the number of suicides, abuse victims, the worsening alcohol and substance abuse rates. Those sociologic factors pale in comparison to the mass destruction of society from this educational baloney of not having kids in school. Even the head of the Israeli COVID effort, who's fairly conservative, said their single biggest mistake was closing schools, period. Biggest single error. It's a lost generation. It's gonna never be made up. I don't know what we're gonna do. I mean, it is terrible what has happened to the socioeconomically poor kids, the kids who went to public schools where the leadership was crappy and fearful. So that's what it is. But let's continue it. Let's continue to keep those kids with the hospitalization rates are slightly up, but again, the death rates are extremely tiny. And there's still, no one will go on record and say how many kids died of meningococcal meningitis in the last year versus COVID. Well, of course, why would we give something that's much more devastating its credence versus something that's not? And when I'm making these comments, it's about population health. It's the individual cases onto themselves are horrible for everyone involved, but we're talking population-based health matters. I'm done. Go ahead.
Okay. Do antibody infusions work for Omicron?
Certain types do work for Omicron. What we do is we just order the antibody infusion, and we are sending everything to Deaconess, and so Deaconess Hospital will give the right type of antibodies if they have them. They also offer remdesivir now infusions on day 1, 3, and 5 with an 83% reduction in the hospitalization, I believe. It's either 83 or 93, sorry. And that's, again, something that is very available. We ordered our first antibody infusion, and I'm blanking on the name, for a high-risk person who has a chronic immune deficiency disease, not HIV or anything, just something they were born with. And so there's a long-acting antibody now available. It's hard to get, but we ordered it for that person, and hopefully they'll be able to get it in before too long, and she'll be able to get it. So there are antibodies specific towards Omicron that work.
Okay. After you get a monoclonal antibody infusion and then you go do antibody blood work, will the numbers be skewed from the infusion?
They can be, yes. So you would probably not want to do that for, and I'll have to look, it's a minimum of 3 months, and it may be 4 to 6.
Okay. Is Omicron...
But hold on, comment. You're going to have antibodies 95% of the time from the infection.
Is Omicron causing blood clots like the other variants did?
I'm sure Omicron is causing blood clots like the other variants did, but it seems to be less, is the preliminary data. I mean, you still have the reports of people having blood clotting, pulmonary embolism, etc., but it does seem to be less. Okay, so that's the talk tonight. Keep your positive thoughts. Know we're getting through the worst of this, and it will be gone. And eventually we'll have a new variant, and we'll have to see how that happens. But we should be going more into the endemic phase, meaning we'll just start cycling through a certain part of the year, kind of like flu. We'll eventually know if we need to do boosters and things like that. I think everyone knows how I feel about repetitive vaccination with the same antigens. Maybe doing a booster with different antigens may help. Oh, the Novavax vaccine may finally be coming out. It's applied for FDA approval. The Novavax is an old style vaccine. It's not messenger RNA. And so that gives people who are very concerned about messenger RNA vaccines a different choice than the J&J. That would be extremely positive. Lastly, there is now a messenger RNA vaccine for HIV, which is really interesting because when we start thinking about how did that HIV mutation get into the furon cleft of the spike protein, was it a monkey having relations with a bat from China and Africa somehow getting together? Or could it have been just maybe someone was researching how to do antibody development against the infectious part of the HIV mutation, or the HIV molecule, whatever, viral particle. So it's just all very interesting stuff that we now have a messenger RNA vaccine potentially on the horizon for HIV, which is so exciting. I'm actually very excited about it. I would love for that to happen. I would love for there to be just to be clear, I would love for there to be an HIV vaccine. I would love for there to be a herpes vaccine. I think that this would be wonderful. We have to take care of a lot of herpes in our practice, and because people have sex, I'm sorry to tell you that, but they do, and things happen. And so it'd be wonderful to be able to offer a herpes vaccine to people who were young before they were sexually active to help prevent that, because it can be very traumatic, obviously. So again, I'm for vaccines that work, that are safe, that have been studied, and I just want them to be used appropriately. That's it. Good night.